So let's just touch on a couple of things that I wanted to go over again. Quantitative versus qualitative research. You definitely need to be familiar with those terms. So quantitative research is more numbers, values, it's measurable. Okay, I guess is really the way that you should think of that. Whereas qualitative is more of like a perception, life experience, verbalized responses. Bias, I don't know if we touched on this last time. Bias is basically anything that can interfere with a study that might change your outcome. So someone might be involved in a study that has a certain bias about something, so they might have information about something or a preconceived idea that can distort the outcome of that study. So you wouldn't want anything or a person or any sort of mechanism that's going to contribute to some sort of bias in a study. So when I have my screen like this, I can't see if you're typing anything. So if you have a question or need to say anything until the end, you're going to have to say it, okay? Because I don't want to go in and out of this. Okay, so I had talked about qualitative research. So some of this stuff I'm going to kind of summarize, or I may skip over if we've already touched on it. All right. Okay, inductive and deductive. I wanted to reemphasize this. So inductive you can think of as assumptive. So I think the example that I had given you last week was you see 12 rabbits, they're all gray, and you just sort of induce, you assume that all rabbits are gray, okay? So it's generalizations based on experience. And this is something that we do every day in our day-to-day life. So it does serve a purpose for us. This isn't always necessarily inaccurate. But if I'm using that inductive reasoning and assuming that all rabbits are gray, when I see a white rabbit, it's going to be pretty, you know, that kind of throws everything out the window. So it's really not as scientific of a thought process. Deductive reasoning, we have testing involved. So you might use the same components of inductive reasoning. You might gather data in the same way and that you're seeing something, but then you're going to verify that in some sort of way. Okay, so it's a little bit more, it has more validity to it. Okay, nursing research. So really the reason that we're talking about a lot of these things is because at some point you might find yourself exploring nursing research, participating in nursing research. It will have some sort of role in your practice. So nursing research is the systemic investigation of phenomena related to improving patient care. So generally, in order for nursing research to occur, at some point someone identifies a problem. And this problem could be based on experience or it could be based on research that they may do. Okay, then we're going to have to come up with some sort of framework for how we're going to figure that problem out. So at some point you may hear of a conceptual framework. So a conceptual framework is something that's frequently discussed in nursing. It's basically ideas or information that can be gathered from previous research. So usually when you're conducting research, one of the places you're going to start is you're going to have to look through the previous research to see what was found out about this problem that you have. So research is how we build our nursing knowledge. That's why we care about it. And, you know, sometimes research, I guess you could say, could be accidental, that someone may not be looking for certain sets of answers, but they find it. But either way, everything we know has come from someone investigating it in some way. Now, the problem in this is that sometimes certain areas are researched far more than others. So one thing that kind of controls research in a sense is funding. There is a push to conduct research that there will be some sort of benefit for, and oftentimes this benefit is monetary. So in a sense, we have to do research that is going to have some sort of influence or people are going to care about. The downside to that is there are some areas of research that just don't get done. For instance, areas of nursing that aren't as, for lack of a better word, popular, they're going to have less research conducted than areas that might be a little bit more supported. I think in general, you're going to find less research in areas like hospice nursing than you will in critical care nursing, just because of, you know, to a certain degree, there's a level of importance. There's a difference there to many people. The Institutional Review Board technically will approve nursing research. However, there are many organizations that will approve that, I guess you could say, and they sort of work together to fund research and to support it. So another organization, the National Institute of Nursing Research, is important. They do a lot of support for clinical research, support for nurses that want to do research. They do a lot of data collection on chronic and acute illness. They're kind of the go-to organization for all things nursing research and promoting research at the educational level, at the university level. All right. So we had talked about the difference between research and problem solving. So just to touch on a couple of these things. So research and problem solving are very similar with some differences, but they kind of overlap. So problem solving is something more so that you do on a day-to-day basis, whereas research is sort of a more intense process. So types of problems addressed. So in research, you have a problem where, as I sort of mentioned before, it has some sort of significant impact usually. So there's usually a reason, there's a motivation, okay? Problem solving is more like, just sort of I mentioned before, a day-to-day basis. You're thinking of the impact probably more so on like one person. So in your own personal life or your own professional life. The conceptual basis. So I don't know if I mentioned this, a theoretical framework. You might have heard this in other classes. A theoretical framework, especially for nursing, is the nursing theories that you use to guide your research. So most nursing researchers will look up some information on nursing theorists and what they have come up with, and then use that to sort of guide research. Whereas in problem solving, you don't use a framework really of any kind. It's trial and error. You kind of do what works. If you're trying to troubleshoot something at your own job, you're probably not going to look up a theoretical framework. You're just going to try something new and see if that works. So it's much less organized. Knowledge base needed. So for research, there's extensive use of literature review. So you have to look at what was done before you. That's called literature review. And then you go from there. In problem solving, kind of like what I was just talking about in the previous topic there, it's kind of just what you know day to day. So practical knowledge and common sense are going to guide you there. Scope of application. So when we do research, we are ultimately researching some sort of problem, but we are hoping that we can utilize it in multiple situations. So usually the problems that we research are not specific enough or to a certain degree where they can be useful for us in many ways. Whereas problem solving, we're really just trying to fix one simple problem. So it's much more specific to the case that we're exploring. Okay, evidence-based practice. I touched on this a little bit. You hear this term, evidence-based practice, all the time. So evidence-based practice is what guides nursing practice. And it's a way that I'm sorry, my cat is hanging from the lampshades. Okay, so it's critical thinking that we use in practice, and it's a way to explore better critical thinking. So all it is to improve our practice. It's basically research that improves nursing practice. Okay, so what I wanted to go to, I want to kind of skip over this stuff. Where was what I wanted to go to? I apologize here. I'll come back to this, but there's something that I wanted to talk about. Maybe I missed it. I don't know. It might be in the next one. So we'll come back to that. Okay. All right. Well, there's something else that I want to mention with this, but we'll come back to that. The research process. So how do we find basically our evidence for evidence-based practice? And that's through the research process. So these are the basic steps here in the research process. So I'm going to go through this. So identification of a researchable problem. Clinical situations, literature, and theory. So first we have to find some sort of problem or identify a problem. Many of the problems that we identify come from clinical situations. So you're working in practice and you realize that this type of Foley catheter always leads to a urinary tract infection in males of this age group. So that's probably very unlikely, but that's just an example. Okay, so then you can use that clinical problem and build on it. So then there's the review of the literature. So you have to go back into nursing journals, published research, and find if anyone else has worked on this problem. So moving forward, when you guys are doing any sort of research, it's very important that you use journal studies. So published research. That is really kind of, I don't want to say the only type of information that's taken seriously, but that's really what we use when we are reviewing literature. Okay. Technically, you only want to review papers that are within the last 5 years. Sometimes you can use 10, but usually it's 5. So you want recent research, the most up-to-date research as possible. Formulation of a hypothesis. So you have to pose some sort of educated guess. You come up with some sort of educated statement and how you think something is working. So I propose that the material of this Foley catheter is easier for microorganisms to adhere to, something like that. Then you have to design a study using some sort of experimental design or some sort of design, okay? So I think I talked about these last time. So we'll skip over that. Data collection, I think I mentioned this possibly too. Just to emphasize for data collection, you have to make sure that whatever you're using to collect data is reliable and valid. So reliability means consistently accurate, meaning that if you do something again and again and again, you're going to come out with the same outcomes. Valid means that it's doing what it's supposed to do. It's measuring the appropriate value. Okay. So implementation is our data collection and our data analysis. So that's basically performing the study. You draw conclusions based on your findings, what your data says, and then you discuss and you release that information. So dissemination of findings is the publication and the presenting of that research. Okay. So these are the steps in the research process. This is actually not just for nursing, this is for science or everything. But the reason why this is important is for you guys to understand that everything that we're doing in practice is based off of this research process. They don't just come up with all of the policies and protocols that we practice because that's what works for them. There is research to back everything up. It's evidence-based. Now, there are people that debate evidence-based practice. So there are some people that think a more theoretical way to do research is more appropriate. I'm not sure that I agree with that, but it's up for debate. The peer review process, to touch on this, peer review is very important. When research is published, it is peer reviewed, meaning other researchers review it, determine the validity of it, and determine if it's appropriate for publication. So not everything that is researched is published. As I mentioned before, one of the biggest barriers to research can be financial support. So there are many organizations that can provide financial support for nursing research. There's also private organizations, hospitals can support nursing research. It's really dependent on what the topic of research is, whether or not you can find funding. And usually a researcher has to find their own funding through grant writing. So they'll document their reason for needing support, and it will get approved or not approved. So levels of educational preparation and participation in nursing research, I'm just going to touch on this. This little chart here is sort of, I guess, what we propose a student at a certain level of education should be prepared to do. So at your level, the BSN level, if you notice, is different than nursing students. So right here, I think they're referring to an ADN program. But a BSN, one of the things that sets a BSN apart from a ADN program is a higher level of research understanding. So in most ADN programs, you are not required to take a class that does any discussion of nursing research, whereas at your level, you are required to. So for a BSN student, they are supposed to be able to come up with their own ideas for what needs to be researched. Meaning, in practice, once you graduate, you could identify areas of improvement, areas of research, and then the ability to start the research process. And then I won't talk about these, but you can see MSN, DNP, and PhD. Now, DNP and PhD, there's a bit of an overlap, but a PhD is considered really an independent researcher, whereas a DNP, they do more practice-based or clinical research, I suppose you could say. So if you're interested in research, the PhD is the route that you would want to go. So this is just sort of reviewing all of those again. Okay, so the purpose of that is I wanted you guys to see some of the main points of this chapter. So that was chapter 10. Now, let me make sure that no one said anything. No, okay, good. I'm going to go into chapter 13. We also talked about some of this stuff last week. So just going to kind of highlight some things here. All right, nurses, patients, and families. All right, systems theory. So systems theory is a theory that we sort of treat groups of people as systems. So the family as a system in systems theory means that if you change any one part of that family, it affects the whole system. And I would say this is a pretty valid theory when we are studying any group of interconnected individuals. And in a family unit, you could consider that a group of interconnected individuals. You could say that a workplace is a system. You could say a school is a system, like a class. You know, it depends on what group of to how significant an acute illness will be. So, for instance, a common cold. Common cold lasts about 5 to 7 days. Maybe 3 to 7, I guess I would say. So a person doesn't always have to be very ill, but they oftentimes do go from one day feeling completely fine to the next day having a series of symptoms. So it's an acute onset. It comes on quickly, lasts a short period of time. Acute appendicitis, same idea. It comes on very rapidly. Acute myocardial infarction, which is a heart attack. Spinal cord injury, I would argue that that would be an acute onset of a chronic illness. So a spinal cord injury is usually going to be an acute event because it happens abruptly. There's no slow buildup to that. However, with the spinal cord injury, you're going to ultimately have chronic outcomes that persist. So chronic illness, I touched on this, develops gradually, requires ongoing medical attention, and it can continue for the duration of the individual's life. And that's not always the case. Some people will have a chronic illness that can sort of go dormant or where they're not having active symptoms. They usually still have the illness. It may just not be affecting them to the same degree. Okay. So examples of chronic illness: diabetes, heart failure, COPD, hypertension. Those are probably the big four that you see in practice. Many patients that you will see in the inpatient environment, outpatient, have either one or many of those chronic illnesses. So with chronic illness, the one good thing, in my opinion, and this is something that I'm pretty passionate about, chronic illness is somewhat preventable. Lifestyle factors play a really big role in chronic illness. If you have type 1 diabetes, you probably can't control that. But type 2 diabetes, we know, is linked to lifestyle factors. So being sedentary, not exercising, obesity, eating too much sugar, smoking, all of these have a direct correlation with the development of chronic illness. So with my patients, I always try to emphasize factors they can control. Maybe at this point they already have their chronic illness, but they can modify that. So if you have a diabetic, they have the ability to manage their own sugar by watching what they're eating and exercising. And those things work. They may still need insulin, but they do have some power over that chronic illness. Losing weight. Obesity is probably one of the biggest factors in all of those 4 chronic illnesses I talked about. So I talked about the term exacerbation. That was where you see someone kind of might go into remission with their chronic illness. You see this a lot with COPD and CHF. Chronic COPDers, they're just up and down, and they'll be real stable, and then something happens. Oftentimes it's environmental, where it's really hot. We have a really hot, humid summer, and they might get a COPD exacerbation. They might be around cigarette smoke or allergens or something like that. So a lot of those things are modifiable, though. So here's a chart that refers to acute versus chronic illness. You can look over that. Okay, so we also talked about the stages of adjusting to illness, or the stages of illness we might have made a reference to last time. So these are likely in this order oftentimes, but I don't know that they always necessarily need to be. I think you probably see them most likely in this order though. So one of the first stages is disbelief and denial. Again, someone having a difficult time understanding that they have an illness or that what they're seeing is attributed to illness. I see this a lot with chronic illness where someone does not understand that their shortness of breath is due to their heart failure. They just think they're tired. They think they're exerting themselves too much. They think that they're just getting old. I mean, they don't make that connection between symptom and disease. And they try to kind of explain it away because I personally think it's something they think they can control. Irritability and anger, pretty self-explanatory. So I don't really know of a better way that I can summarize these. Basically, either anger at themselves, the person that's trying to take care of them. You may get some lashing out at caretakers, at healthcare staff. I see this a lot with the diagnosis of terminal or a very significant diagnosis. See this a lot after very aggressive surgeries, like coronary artery bypass surgeries, CABG surgeries, where someone is just sort of shocked that they had open heart surgery and they have difficulty adjusting and they get very irritable and angry afterwards. Especially younger people. Oftentimes younger individuals struggle with these much more than someone who's 80. Not always the case, but it's what I see the most. Attempting to gain control. Oftentimes with this, you'll see a somewhat aggressive control approach, kind of going overboard, maybe. The use of medications that may not be appropriate, consulting multiple different healthcare providers looking for answers, a lot of Google MD, looking for different ways they can control the situation. And this isn't always a bad thing. I encourage patients to a certain degree to take control of their own illness. I think it only becomes problematic if they are going overboard and they are looking for answers that maybe aren't there or inappropriate things. Depression and grief. I think that I see this more frequently in something that's terminal or if it's very life-changing, like a spinal cord injury. Although you could experience this probably with someone that becomes a diabetic. I think an example of something that is still manageable, like diabetes or heart failure, they may become sort of reclusive and not participate in the normal things that they wanted to out of fear, out of the acknowledgement that they're mortal, I guess, that their life is changing, that they're not going to go back to the way that they were before. Which is a hard reality for many people, as you would imagine. Acceptance and participation. So this is kind of the place that we all hope that a patient gets to, where they can contribute to their own healthcare, where they can participate in a meaningful way, where they acknowledge the things that they need to do. And I will say, for chronic illness, this is not always a given. So some people, it takes them a very long time to get to a place where they have the understanding of how to participate in their own care. I have diabetics or CHFers that they don't understand how to control their blood sugar for months and months and months. Or I have a diabetic patient now who, you know, her blood sugar, the last time I saw her, was 222. And I asked her what she ate for breakfast or dinner the night before or something like that. And she said, oatmeal. Oatmeal's healthy. And I said, well, what did you put in the oatmeal? She said it was apple cinnamon. Okay, so it was prepared oatmeal with tons of sugar. So this patient is attempting to participate, but she really either has not been given the tools to do so, or, you know, or she just really isn't maybe going to get it. So in her situation, it takes a little bit more education to get her to the point where she can truly kind of take control and participate in what we need her to do. All right, what else? I don't want to talk about this right now. Cultural competence, I know that we discussed a little bit, but just to emphasize or to go over this again. The definition, according to the text, having the attitudes, knowledge, and skills necessary for providing quality care to diverse populations. So understanding that there are people different than you, and they may have different needs than you, and you don't necessarily need to know what those needs are. You just need to acknowledge that they may be different, is really what it is. You can always learn that, but you have to go into situations open to that knowledge. So focus of patient-specific needs shaped by their culture, because that really does influence a lot of our healthcare needs. The culturally competent nurse is more likely attuned to health disparities, because those are very significant. I think it really depends on what area of healthcare you end up working in for you to recognize those disparities. But there is a significant difference in populations across culture, in all different ways. And you'll find that certain groups just don't have the resources, they don't have the knowledge sometimes. And so they oftentimes don't have a chance to make the best choices based on that. So you have to be understanding and sort of meet them where they're at. So that's a term that you'll hear pretty frequently, meeting someone where they're at. I have patients that can't afford their medications. So of course it's my job to educate them and say, yes, you do need this medication, but I also have to be realistic that, and sort of culturally or socioeconomically competent, that may not be realistic for them. Non-compliant. So that's a really interesting point. You will have many non-compliant patients. And in healthcare, I think we document non-compliant as sort of like a bad child. This person's non-compliant. They didn't do what I told them to do. Well, oftentimes someone is not doing that by choice. They don't have any other options. So you have to look at compliance from their own view, their own perception. All right. Personality characteristics that can dictate how a person manages their illness. I talked about some of these last time too. Dependence and independence. I see some patients that are completely dependent on the people around them to make decisions for them, to do things for them. Realistically, they are not going to have the ability probably to take on this additional task. Coping ability. Some people are better at coping than others. The people that are better at coping oftentimes handle an illness diagnosis or managing an illness better. Resourcefulness, that ability to problem solve, really, to come up with new ideas, to handle something with the best information or resources that you have. I usually kind of find that hand in hand with coping. Resilience, the ability to bounce back when you're given bad news, to still be able to move past that devastation. Spirituality and religion. This is a personal preference. Some people really depend on spirituality and religion, and I think at times it helps them cope. But then also just wellness in general, which is kind of listed here. Someone that prioritizes wellness, emotional and physical, I typically see better outcomes with those people. Which is why I really personally encourage wellness in all ways in patients. And I don't know that medically that is always something that is done. So this is an interesting topic to me, the meeting of spiritual needs of patients. In my experience through hospice nursing, there was a really significant spiritual component with that. And I don't see that in many other areas of nursing. I don't think that there's necessarily anything wrong with that. I think it's just the nature of hospice. But I will say it sort of influenced my own perceptions of that. And according to the text, nurses are reluctant to provide spiritual nursing care for a variety of reasons. I think a lot of nurses don't, we're not really taught that. We're not really taught, and spirituality does not mean religion necessarily. It's sort of a person's own outlook on the world and their place in it is really more of what spiritual meaning means. You can kind of think of it as holistic. Seeing a person as more than just like their physical body, everything. And then oftentimes there is a religious component to that, but it doesn't really necessarily have to be. So nurses might feel that they just don't have an understanding. They're overstepping bounds. They don't want to get very personal with a patient. They may not know how a patient feels about their beliefs or wanting to share their beliefs or their needs. Lack of time is a big one. We get very task-based in nursing. We have a tendency to ignore the simple things like, do you need a new pillow? Did you eat all of your food? The things that really make a difference in people's lives. So it is important to, I guess, try not to be as task-based and a little bit more holistic of a thinker. Spiritual distress is actually a nursing diagnosis. I actually think it's risk for spiritual distress specifically, but it's impaired ability to experience and integrate meaning and purpose in life through connectedness with self, others, art, music, literature, nature, and the power greater than oneself. So that's what spirituality is. It's basically just sort of our idea of how we interact with the world and if we get fulfillment from those things. So it is important to identify that in patients. Like I said, risk for spiritual distress is a nursing diagnosis, meaning that if you see someone that just doesn't seem to have good insight in their meaning or their connectedness to their family and friends, that's going to be a problematic for their long-term care. All right. So I already talked about cultural competence. Be familiar with that. So I'm not going to go. Stereotyping, I believe we mentioned a little bit of this. You know, stereotyping, I think, it's everyone does it to a certain degree. But you, as a nurse, you really have to get away from that, because you will find that some stereotypes that you may hold aren't always the case. So you really need to try or attempt to go into situations with a completely, like, you know, free mind. Easier said than done. But I think that when you, I guess, work with more people and see different things, that becomes a little bit easier. I talked about the definition ethnocentrism. So this is important. Remember that. It's the inclination to view one's own cultural group as the standard by which to judge the value of other cultural groups. So you sort of think that your way of doing things is how everyone does things. And that's obviously not the case. So in order to be a, you know, a culturally competent nurse, you really need to identify your own cultural, emotional needs and have a good understanding of yourself so that you can have a more empathetic understanding of another. So I think it's probably not done as much as it should be, but we should all sort of assess what our own goals and values are. So, you know, things like end of life care or code status and things like that. What would you want? And then when you're having a discussion with a patient, you don't necessarily have to use your own beliefs or wants or needs in that. But in identifying that, I think it makes it easier to understand someone else's needs, even if they differ from your own. So we talked a little bit about this before. Stress and illness. As you would imagine, stress typically will make illness worse. You know, we tell people to not stress, de-stress. That's not really always doable when someone's very ill. But we have to understand that oftentimes stress can lead to anxiety as well. And anxiety can be very destructive to a patient's overall wellness. If a patient is having a significant issue with anxiety, a provider should intervene in some way, whether it be medication interventions or social work consult or something. Anxiety is not really going to be manageable alongside chronic illness. And part of that is because it can greatly affect hormones, one of those being cortisol. The more stressed and anxious you are, the more cortisol is secreted. And that does a lot of crazy things to the body. It can actually reduce the immune response and make you at a higher risk for illness. So that's why a lot of times when you're stressed, you get a cold because of that cortisol secretion. So we want to do our best to manage or help a patient manage their anxiety, because it really is going to allow them to heal faster. Part of that is giving a patient ways to cope. And this is how I like to involve as many people in patient care as I can. I really like to get the social workers involved. If I'm working in an inpatient unit, maybe that means a referral to some sort of mental health service, therapeutic service in some way. Obviously, as a nurse, you can't do it all. So it's important to utilize all of your resources, all of the people that you have that can possibly help this patient manage this situation. And patient education. Oftentimes, a patient does not know what they're experiencing is stress or anxiety. You know, if they've never been in this situation, they may not know. So you can give them an outward sort of view of what's happening. Barriers to learning. Okay. So when we're trying to educate patients on their acute or chronic illness, there are several things that can prevent this education from occurring. And one of those that I just mentioned is anxiety. If someone is very anxious, you're not going to be able to communicate with them effectively. Physiologic factors, visual and hearing deficits, unmet needs, pain. If someone is having really bad pain, that is not the time to sit down and have a discussion with them. Okay? You should treat the pain first and then educate them on their disease process. Culture and meaning of illness. So there can be cultural limitations, and that can be just due to exposure. There may be cultural practices that someone believes in that we have found may not have an effect, but it can be difficult to educate someone that may not be the best way. And I'm hesitant to take anything away from someone. So if they have a cultural practice, I usually try to incorporate it. Some physicians may disagree. I've heard of physicians not believing in things like chiropractic medicine and acupuncture and things like that. But if things can be done simultaneously, I think it's important to make it work together. Lack of motivation and readiness. Sometimes people are just not ready to hear what you have to say. And there's nothing you can do about that. Private, comfortable, and free of distractions. We always want to make sure that we are educating someone in a way that they're comfortable. So this is probably one of the big downsides to virtual learning, right? I don't know that us being in our homes is really the best way for information to be shared. You've got kids and animals and distractions and phone calls and all these things. That's not really the best environment conducive to learning. And the same thing goes with patient education. When I go into homes and try to educate patients, the wife's cooking dinner, the son is knocking on the door, the daughter's calling. There's oftentimes a lot of barriers to me really getting my message across. So trying to set the perfect stage for this is not always possible. All right. Okay, so I think I'm going to stop there today. We just have a little bit for this chapter. Oh my gosh, I think people were saying things and I couldn't see anything. Okay, good. Okay, so chapters 10, 13, and 16, again, are up in on Canvas. So I would definitely encourage you to utilize those. Next week, we meet again at 1 o'clock. And then the week after is the exam. So we have a little bit more to talk about before the exam. Okay. And I actually think that's all. Does anyone have any questions about any of those things? You have a question about something else? Let me stop sharing this. This is too confusing. That's going to be due the last day of class. And I was talking to another instructor, and I didn't get any answers. But what I'm going to end up having you guys do is just send me one of the pieces of it via email, because we don't have a Dropbox and there's no way to add one. So like the last week of class, I'll have you all just send it to me via email, and I'll do my best just keeping it all straight, because that's going to be kind of chaotic, but that's what I'll do. If you're done with it, you can actually send me, you can just send me a screenshot or a picture of one of the pieces, and that's going to have to suffice. Okay. Okay. All right, guys. So then we will meet again next week at 1. Have a good Thanksgiving. Someone's typing. Let me make sure it's not a question. Or if you, yes. Okay. That's what it is. All right. Yes. Have a good Thanksgiving. Stay safe. And we will meet again next week. Okay.